You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about ASCVD risk estimation and lipid lowering. We'll talk about LDL targets, 10-year ASCVD risk estimation and levels of statin intensity, statin intolerance, non-statin therapies, and lipid panels. Let's start with LDL targets. What level of low-density lipoprotein cholesterol should you target? If it seems to you like the target is nebulously shifting, it's not your fault. I will simplify it for you right now based on the recommendations of the 2022 ACC Expert Consensus Decision Pathway on the role of non-statin therapies for LDL cholesterol lowering in the management of atherosclerotic cardiovascular disease risk. For secondary prevention, for everyone who has an ASCVD event, the goal LDL is less than 55 if they are very high risk of additional ASCVD events, and less than 70 if they are not at very high risk for additional ASCVD events. And ASCVD events includes things like myocardial infarction, acute coronary syndrome, or stroke. The 2022 ACC Expert Consensus Decision Pathway defines very high risk of additional ASCVD events as having at least either 2 events or 1 event and 2 conditions. The events possible are recent ACS, recent acute coronary syndrome within the last 12 months, myocardial infarction other than above, ischemic stroke, or significant peripheral artery disease, defined as claudication with ankle-brachial index less than 0.85, revascularization, or amputation. The conditions in the category of very high risk of additional ASCVD events are current smoker, diabetes mellitus, hypertension, at least 65 years of age, LDL still remaining 100 maximally tolerated statin and ezetimibe, heterozygous familial hyperlipidemia, prior CABG or PCI that did not count in a major ASCVD event category, chronic kidney disease with an eGFR of 15 to 59, or history of congestive heart failure. So there's a lot of ways for patients to qualify for very high risk of additional ASCVD events because you need at least 1 event and at least 2 conditions, or you need at least 2 events. So that is for secondary prevention. How about for primary prevention? The LDL goal is generally 100 or less, except in diabetes patients. If a diabetes patient's ASCVD risk is at least 20% or more, the goal LDL is less than 70. If a diabetes patient's ASCVD risk is less than 20, then to decide whether or not the goal is less than 70 or less than 100, see if they have diabetes risk enhancers. These are diabetes type 2 for 10 years or diabetes type 1 for 20 years, a urine albumin of at least 30 micrograms per mg of creatinine, eGFR of less than 60, retinopathy or neuropathy, or ankle-brachial index less than 0.9. To recap, for secondary prevention, for everyone who has had an ASCVD event such as MI or stroke or ACS or significant PAD, the goal LDL is less than 55 if they are very high risk of additional ASCVD events, and the goal is less than 70 if they are not at very high risk for additional ASCVD events. For primary prevention, the LDL goal is generally 100 or less, except in diabetes patients. In diabetes patients, if the ASCVD risk is 20% or more, goal LDL is less than 70. If the diabetes patient's ASCVD risk is less than 20%, then to decide whether or not the goal is less than 70 or less than 100, see if they have those diabetes risk enhancers. Let's move on to the 10-year ASCVD risk estimation and statin intensity. What do the 2019 AHA-ACC guidelines say about the 10-year risk assessment for primary prevention? For adults 40 to 75 years of age, clinicians should routinely assess traditional cardiovascular risk factors and calculate 10-year ASCVD risk by using the pooled cohort equations. That's a Class 1 recommendation. However, please note that the pooled cohort equations have since been replaced by the new PREVENT equations released by the AHA in 2023, which I will mention later in this episode. For adults 20 to 39 years of age, it is reasonable to assess traditional ASCVD risk factors every 4 to 6 years, Class 2A. In adults at borderline risk or intermediate risk, meaning 5 to 7.5% of 10-year ASCVD risk or 7.5 to 20% 10-year ASCVD risk, respectively, it is reasonable to use additional risk-enhancing factors to guide decisions about preventive interventions such as statin therapy. That's a Class 2A recommendation. In adults at intermediate risk, which is 7.5 to 20% 10-year ASCVD risk, or selected adults at borderline risk, which is the 5 to 7.5 category percent of 10-year ASCVD risk, if risk-based decisions for preventive interventions such as statin therapy remain uncertain, it is reasonable to measure a coronary artery calcium score to guide clinician-patient risk discussion, Class 2A. For adults 20 to 39 years of age, and for those 40 to 59 years of age who have less than 7.5% 10-year ASCVD risk, estimating lifetime or 30-year ASCVD risk may be considered, Class 2B. What does high, moderate, and low intensity statin mean? These are classifications based on the degree of LDL cholesterol reduction they typically provide when used at standard dosages. Low-intensity statin decreases LDL by less than 30%. Moderate-intensity statin decreases LDL by 30 to 50%. High-intensity statin decreases LDL by more than 50%. Only rosuvastatin and atorvastatin have doses that count as high-intensity statin, and those are rosuvastatin 20 and 40 milligrams and atorvastatin 40 and 80 milligrams. Everything else is moderate intensity or less. Should a statin be used, and what level of statin should be used? Let's go over the famous flowchart from the 2019 ACC-AHA guidelines on primary prevention, which were adapted from the 2018 ACC-AHA guideline on the management of blood cholesterol. This is a chart that many of you are familiar with, as it has been tested at every level, from USMLE Step 2, 3, ABIM Internal Medicine, and ABIM Cardiology board exams. If you need a refresher on this chart, you can either visit the 2019 AHA-ACC guidelines, or you can download the statin primer handout from my website. First of all, which two populations do you bypass the entire chart and go straight to a high-intensity statin? One is, if the LDL is 190 or higher, that automatically buys you a high-intensity statin, regardless of age group, and you skip the chart. The 2019 AHA-ACC guidelines say, in their own words, in patients 20 to 75 years of age with an LDL-C level of 190 milligrams per dil or higher, maximally tolerated statin therapy is recommended. That's a Class 1 recommendation. The second group, where you can just bypass the entire chart and go straight for a high-intensity statin, is anyone who experienced an ASCVD event. Unless the age is over 75 years, then you can downgrade to a moderate-intensity statin. Other than acute coronary syndrome and stable angina, things that count as having a clinical ASCVD event are stroke, TIA, prior coronary or other arterial revascularization, and PAD, peripheral artery disease. Assuming you don't have those two factors of LDL more than 190 or an ASCVD event, you can now focus on the main chart for primary prevention for people with LDL 70 to 189. Among 40 to 75-year-old adults without diabetes, the cutoffs are 5%, 7.5%, and 20%. If the 10-year ASCVD risk is under 5%, i.e. low risk, lifestyle changes are sufficient. If the 10-year ASCVD risk is 5% inclusive to 7.5% exclusive, that's borderline. To decide between lifestyle changes only versus adding a moderate intensity statin, see if there are any primary prevention risk enhancers, which I'll cover below. If 10-year ASCVD risk is 7.5% inclusive to 20% exclusive, that's intermediate risk. Moderate intensity statin is needed, but if you need further prompting to be sure about your decision, see if there are any primary prevention enhancers. Let's see how exactly the guidelines word this. In adults at intermediate risk, meaning 7.5 to 20% 10-year risk of ASCVD, statin therapy reduces risk of ASCVD, and in the context of a risk discussion, if a decision is made for statin therapy, a moderate intensity statin should be recommended. Class 1 recommendation. In intermediate risk patients, meaning 7.5 to 20% 10-year ASCVD risk patients, LDL-C levels should be reduced by 30% or more. And for optimal ASCVD risk reduction, especially in patients at high risk, more than 20% of 10-year ASCVD risk levels should be reduced by 50% or more, class 1. In intermediate risk adults, meaning 7.5 to 20% 10-year ASCVD risk enhancing factors favor initiation or intensification of statin therapy, class 2A. If 10-year ASCVD risk is 20% and up, that's high risk and high intensity statin is needed. Remember, the guidelines say in patients at borderline risk, defined at 5% to 7.5% 10-year ASCVD risk, in risk discussion, the presence of risk-enhancing factors may justify initiation of moderate-intensity statin therapy, class 2B. So, for this 5 to 7.5% group, what are the primary prevention risk enhancers? There is history and comorbidities, lipids and biomarkers, and select labs as measured. So in history and comorbidities, you can look at whether the patient has a family history of premature ASCVD, if they have ethnicity-related risk factors such as being of South Asian descent, chronic kidney disease, metabolic syndrome, inflammatory disease, especially rheumatoid arthritis, psoriasis, or HIV, and conditions specific to women such as preeclampsia or premature menopause. In terms of lipid or biomarkers, primary prevention risk enhancers are LDL of 160 or higher and persistently elevated triglycerides of 175 or higher. In select individuals if measured, a high sensitivity CRP of 2.0 or higher, an ankle brachial index less than 0.9, an Lp(a) of more than 50 milligrams per deciliter or 125 nanomoles per liter, and apolipoprotein B of more than 130 milligrams. The Lp(a) in this context can be checked if there's a family history of premature ASCVD, and the apolipoprotein B can be checked if the triglycerides are more than 200. These are the factors which, if any of them are present, can prompt you to initiate moderate intensity therapy in 40 to 75-year-old adults without diabetes whose 10-year ASCVD risk is 5 to 7.5%. Also, in 40 to 75-year-old adults without diabetes whose 10-year ASCVD risk is 7.5 to 20%, these are the factors that can help solidify your decision to initiate moderate intensity statin therapy, just that the class of recommendation is stronger for the 7.5 to 20% 10-year risk group than for the 5 to 7.5% 10-year risk group. How about 40 to 75-year-olds with diabetes? All adults with diabetes should be on a moderate intensity statin. Unless they have diabetes-specific ASCVD risk-enhancing factors, then they should be bumped to a high-intensity statin. Of course, I'm talking about 40 to 75-year-old adults with diabetes. And what are these ASCVD risk-enhancing factors that are diabetes-specific? I mentioned them earlier at the start of the episode, and I'll mention them again here. So that's a long duration of diabetes, which is at least 10 years of diabetes type 2 or at least 20 years of diabetes type 1. Albuminuria, which is defined as at least 30 micrograms of albumin per milligram of creatinine. eGFR of less than 60. Retinopathy, neuropathy, and ankle brachial index of less than 0.9. These are the diabetes-specific ASCVD risk-enhancing factors that, if present, should bump an adult with diabetes from a moderate-intensity statin up to a high-intensity statin. In adults 40 to 75 years age with diabetes, regardless of estimated 10-year ASCVD risk, moderate intensity therapy is indicated. And in adults with diabetes mellitus who have multiple ASCVD risk factors, it is reasonable to prescribe high intensity statin therapy with the aim to reduce LDL-C levels by 50% or more, class 2A. So I just gave you the two corresponding statements in the guidelines, class 1 and class 2A, that reflect what we just talked about for 40 to 75-year-olds with diabetes. You can also do the MESA risk score. That's a score that adds the coronary calcium to cardiovascular risk. So we talk a lot about calcium scoring, coronary artery calcium scoring. What do you do about a CAC score result? Recall that there's this class 2A recommendation I mentioned earlier in the episode. In adults at intermediate risk, meaning 7.5 to 20% of 10-year ASCVD risk, or selected adults at borderline risk, meaning 5 to 7.5% of 10-year ASCVD risk, if risk-based decisions for preventive interventions with statin therapy remain uncertain, it is reasonable to measure a coronary artery calcium score to guide clinician-patient risk discussion. There is an accompanying recommendation about what to do once you get the CAC score. In intermediate risk adults, meaning 7.5 to 20% 10-year ASCVD risk, or selected borderline risk adults, meaning 5 to 7.5% 10-year ASCVD risk, in whom a coronary artery calcium score is measured for the purpose of making a treatment decision, the following are Class 2A recommendations. If the coronary artery calcium score is 0, it is reasonable to withhold statin therapy and reassess in 5 to 10 years, as long as high-risk conditions are absent, such as diabetes, family history of premature CHD, and cigarette smoking. If coronary artery calcium score is 1 to 99, it is reasonable to initiate statin therapy for patients of at least 55 years of age. If coronary artery calcium score is 100 or higher, or in the 75th percentile or higher, it is reasonable to initiate statin therapy. In other words, if CAC is 0, no need statin unless diabetes, family history of tobacco use. If CAC is 1 to 99, use a statin, especially age 55 or higher with an LDL goal of less than 100. If CAC is 100 or more, use a statin with an LDL goal of less than 70 and add ezetimibe if needed. There's a situation where CAC is 0, and you might think, well, the chances of that are so rare. Should we even do this test? But the guidelines offer 4 examples of candidates who might benefit from knowing that their coronary artery calcium score is 0. First group is patients reluctant to initiate statin who wish to understand their risk and potential for benefit more precisely. Second is patients concerned about the need to reinstitute statin therapy after discontinuation for statin-associated symptoms. Third group is older patients, men 55 to 80 years of age and women 60 to 80 years of age, with a low burden of risk factors who question whether they would benefit from statin therapy. And the fourth group is middle-aged adults, 40 to 55 years of age, with a 10-year risk of ASCVD 5 to 7.5%, with factors that increase their ASCVD risk, although they are in a borderline risk group. Those are the 4 examples of candidates who might benefit from knowing their coronary artery calcium score is 0. Now, in terms of the 10-year risk equation, it used to be pooled cohort equations for over a decade, but very recently, the AHA's PREVENT equations, meaning predicting risk of CVD events. Their PREVENT equations represent an update of the risk assessment tool these were just released in November 2023. The PREVENT equations expanded the age range included in the risk equations. It now permits calculation for ages 30 years to 79 years instead of the prior restrictive limit of 40 to 75 years. PREVENT allows for the estimation of not just a 10-year risk but also 30-year risk. It also allows for the estimation of heart failure risk, in addition to the risk of coronary heart disease and stroke. It allows for sex-based estimation of risk and removed race as a variable. PREVENT also added new risk factors in the equation, including body mass index, glycated hemoglobin for diabetes severity, and urine albumin-creatinine ratio, as well as the social deprivation index. Now that we've talked about 10-year risk estimation, let's talk about statins and statin intolerance. Statins act by competitively inhibiting the enzyme beta-hydroxy beta-methylgluteryl-CoA reductase, or HMG-CoA reductase, a key enzyme in the mevalonate pathway responsible for cholesterol biosynthesis. By inhibiting this enzyme, statins effectively reduce the synthesis of cholesterol in the liver. This reduction in intracellular cholesterol levels triggers a compensatory mechanism involving the upregulation of low-density lipoprotein receptor expression on hepatocyte surfaces. Consequently, there is an increased uptake of circulating LDL cholesterol by hepatocytes, leading to a decrease in the circulating LDL cholesterol levels. So that's how statins work. Some degree of statin intolerance is reported by 5 to 30% of patients, although the incidence and prevalence varies by population studied and setting. In the most updated definition of statin intolerance from the National Lipid Association in 2022, statin intolerance is defined as one or more adverse effects associated with statin therapy, which resolves or improves with dose reduction or discontinuation, and can be classified as complete inability to tolerate any dose of a statin or partial intolerance with inability to tolerate the dose necessary to achieve the patient-specific therapeutic objective. To classify a patient as having a statin intolerance, a minimum of 2 statins should have been attempted, including at least 1 at the lowest approved daily dosage. So, one of the new features of the 2022 definition from National Lipid Association is that they have 2 categories, complete and partial. Complete statin intolerance is inability to tolerate any dose or regimen of a statin. Partial statin intolerance is the ability to tolerate a lower dose of statin than is required to achieve the desired therapeutic objective. For patients with sustained statin intolerance, clinicians should attempt multiple strategies to identify a tolerable statin regimen. For example, a lower dose, switching statins, non-daily dosing, because complete statin intolerance is uncommon in less than 5% of patients. That's a class 1 recommendation. You should try 2 and ideally 3 statins with 1 month of washout in between, and also try non-daily dosing such as thrice weekly or once weekly statin. Reversible elevations of hepatic transaminases are almost always asymptomatic and rarely require stopping of statins. At equivalent statin doses, Asians achieve greater LDL lowering than Westerners, so consider starting at a lower dose at 1/4 of the dose. Also, the incidence of myopathy is 10 times higher in Asians on the same statin as in Caucasian Americans. Necrosis, which consists of muscle aches and weakness and serum creatinine kinase exceeding 10 times normal, occurs in less than 0.5% of patients on statins. Myonecrosis, of course, requires immediate discontinuation of statins. Simvastatin has interactions with many drugs, leading to myopathy or rhabdomyolysis. When you are on verapamil or diltiazem, you must not exceed 10 mg per day of simvastatin. When you are on amiodarone, amlodipine, or ranolazine, you must not exceed 20 mg a day of simvastatin. Pravastatin is the one statin that is not metabolized by the CYP3A system, so the risk of myopathy is not increased by the use of CYP3A inhibiting drugs. Atorvastatin, lovastatin, and simvastatin are metabolized by CYP3. Fluvastatin, pitavastatin, and rosuvastatin are metabolized by CYP2C9. Atorvastatin, simvastatin, fluvastatin, lovastatin, and pitavastatin are the lipophilic ones, thus more widely distributed in tissues, including muscle. Pravastatin and rosuvastatin are the hydrophilic ones, more selective for the liver and less likely to penetrate non-hepatic tissues such as muscle. In patients with statin intolerance, consider switching over from a lipophilic statin to a hydrophilic statin such as pravastatin or rosuvastatin that is more selective for the liver and less likely to penetrate non-hepatic tissues such as muscle. For patients with known or suspected statin intolerance who are at high or very high ASCVD risk, the guidelines say non-statin therapy should be considered while additional attempts are made to identify a tolerable statin regimen to avoid excessive delay in lowering atherogenic lipoproteins, class 2A. Now we can move on to non-statin therapies. We are all very familiar at this point with statins, statin side effects, statin intolerance, and different strategies for statin adherence. What are the non-statin therapies available to us? We are quite fortunate to be living in a time when there are many medications other than statins that can help achieve cholesterol lowering. Let's go through these ones, starting with ezetimibe. Ezetimibe inhibits cholesterol absorption in the small intestine. It achieves this by selectively binding to the transmembrane protein Niemann-Pick-C1 like NPC1L1 on the brush border of enterocytes. By binding to NPC1L1, ezetimibe prevents the uptake of cholesterol-rich micelles from the intestinal lumen into enterocytes, thereby reducing the amount of cholesterol absorbed from the diet into the bloodstream. How about bempedoic acid? This is a relatively new one. Bempedoic acid inhibits adenosine triphosphate citrate lyase, ACL, an enzyme involved in cholesterol biosynthesis upstream of HMG-CoA reductase. By inhibiting ACL, bempedoic acid disrupts the production of mevalonate, a precursor molecule in cholesterol biosynthesis. Then you have PCSK9 inhibitors, proprotein convertase subtilisin casein type 9 inhibitors, such as alirocumab, evolocumab, and bococizumab. These function by blocking the activity of PCSK9, a serine protease involved in LDL receptor degradation. By inhibiting PCSK9, these monoclonal antibodies prevent the degradation of LDL receptors on hepatocytes, thereby increasing the availability of LDL receptors for binding and uptake of LDL particles from the bloodstream, ultimately resulting in decreased LDL cholesterol levels. Inclisiran is a small interfering RNA or siRNA that targets PCSK9 messenger RNA. By binding to PCSK9 mRNA with the assistance of the RNA-induced silencing complex, or RISC, RISC, inclisiran inhibits the translation of PCSK9 mRNA into PCSK9 protein. This results in reduced levels of PCSK9 protein, leading to increased expression of LDL receptors on hepatocytes and enhanced clearance of LDL cholesterol from the bloodstream. Fibrates, which are not used as much these days, activate the nuclear transcription factor peroxisome proliferator activated receptor alpha, PPAR alpha. Upon activation, PPAR alpha modulates the transcription of genes involved in lipid metabolism, including those encoding apolipoprotein A1, apolipoprotein A2, lipoprotein lipase, and fatty acid oxidation enzymes. This results in increased expression of LPL and reduced expression of ApoC3, leading to enhanced clearance of triglyceride-rich lipoproteins from circulation. Fibrates also stimulate hepatic fatty acid oxidation, which contributes to decreased hepatic triglyceride synthesis. Collectively, these actions lead to a reduction in serum triglyceride levels and a modest increase in HDL. Next is niacin, which is also not used as much these days. Niacin is a tryptophan derivative called vitamin B3. It reduces hepatic synthesis of very low-density lipoprotein, thereby causing a reduction in LDL. Niacin also inhibits lipolysis by hormone-sensitive lipase in adipose tissue, thereby reducing the release of free fatty acids from adipocytes that are needed by the liver for triglyceride synthesis. So niacin leads to a reduction in triglycerides. Niacin is no longer commonly used these days because of side effects of flushing, hepatotoxicity, hyperuricemia, hyperglycemia, and gastritis limited patient tolerability. And more importantly, the AIM-HIGH and HPS2 THRIVE trials showed that addition of niacin to statins did not further lower cardiovascular events compared to statin alone. Omega-3 fatty acids are making a comeback. Omega-3 fatty acids such as eicosapentaenoic acid, or EPA, when incorporated into cell membranes, competes with arachidonic acid for the production of eicosanoids, leading to synthesis of less inflammatory and thrombogenic mediators. Additionally, eicosapentaenoic acid activates peroxisome proliferator activated receptors, PPAR, which I mentioned a few paragraphs ago, which regulate gene expression involved in lipid metabolism, inflammation, and vascular function. By modulating these pathways, omega-3 fatty acids exert an anti-inflammatory, anti-thrombotic, and antiarrhythmic effects, ultimately contributing to improved cardiovascular outcomes. Eicosapentaethyl is different from over-the-counter fish oil preparations in that it contains a high concentration of purified eicosapentaenoic acid ethyl ester. The standard approach is statin, then ezetimibe, then PCSK9 inhibitor. We will await further guidance from future guidelines on how to choose between inclisiran, bempedoic acid, eicosapentaethyl, and the other emerging therapies. Now, there are a few interesting pearls from the 2021 National Lipid Association scientific statement on lipid measurements that I want to bring to your attention because they are common questions that I am sure you have and your patients and families have. First is, do you need to be fasting? Fasting lipid specimens are recommended. That's class 1 recommendation from the National Lipid Association. but they also allow for non-fasting. Non-fasting lipid specimens are reasonable alternatives to fasting specimens, class 2A. It is recommended to follow up abnormal screening lipid measurements with fasting lipid measurement, that's class 2A. In practice, I find that in general, we are quite permissive of having patients do non-fasting lipid specimens, but if the triglycerides ends up being high, more than over 150 or so, then we get them to do a fasting specimen. And it also depends on whether your chemistry lab is performing a direct LDL cholesterol measurement or using a calculated cholesterol measurement. So let's go over what that means. Which equation should you use to estimate the LDL-C? The most common equations that exist are the Friedewald equation and the Martin-Hopkins estimation. So you may have heard of the Friedewald equation from medical school. These are the two methods used to estimate LDL cholesterol when LDL cholesterol is not measured directly in lipid panel. So the Friedewald equation is LDL-C equals total cholesterol minus HDL-C minus triglycerides divided by 5. This Friedewald equation assumes a fixed ratio of triglycerides to VLDL cholesterol, which may not always be accurate, especially in patients with metabolic syndrome, diabetes, or lack of fasting. Again, the equations LDL equals total cholesterol minus HDL minus, in brackets, 1/5 of triglycerides. Because of a negative bias associated with elevated triglyceride levels, fasting specimens are really important for the Friedewald equation, and the LDL cholesterol estimate is considered inaccurate if triglycerides exceeds 400 milligrams per deciliter. Therefore, the 2021 NLA scientific statement says the Friedewald estimation is reasonable for LDL cholesterol of at least 100 milligrams per deciliter and triglycerides under 150 milligrams per deciliter. That's a class 2A recommendation. In contrast, the formula in the Martin-Hopkins method uses a variable factor for triglycerides rather than a fixed division by 5 that is used in a Friedewald equation. The Martin-Hopkins equation is LDL cholesterol equals total cholesterol minus HDL cholesterol minus the triglycerides divided by a personalized factor. The personalized factor for dividing triglycerides is determined by matching the patient's non-HDL cholesterol and triglyceride levels to a lookup table derived from a regression of extensive clinical research data. So it's not just one number like 1/5. Therefore, the leeway for triglycerides is much higher when you are using the Martin-Hopkins equation. The 2021 NLA scientific statement says the Martin-Hopkins estimation is reasonable for LDL cholesterol less than 100 mg per deciliter when triglycerides is less than 400 milligrams per deciliter. That's a class 2A recommendation. Now, what about red flags? The NLA scientific statement says LDL cholesterol in adults exceeding 190 milligrams per deciliter inclusive is recommended to be reported as possible familial hypercholesterolemia. That is a class 1 recommendation. Non-HDL cholesterol in adults exceeding 220 milligrams per deciliter inclusive is recommended to be reported as possible inherited hyperlipidemia. Triglyceride concentration exceeding 500 milligrams per deciliter inclusive is recommended to be reported as severe hypertriglyceridemia, so a class 1 recommendation. Lastly, how often do you need to be checking lipids? Lipid measurements are recommended at 3 to 12 months for those on a stable medication regimen. That's a class 1 recommendation. Lipid measurements are recommended 4 to 12 weeks after a change in lipid treatment. That's a class 1 recommendation. Follow-up lipid levels may be reasonable to obtain in acutely ill or recently hospitalized persons, class 2B. So now we have gone over the different LDL targets in each population, the 10-year ASCVD risk estimation and different levels of statin intensity in each population, statin mechanism and statin intolerance, non-statin therapies and their mechanisms, and common questions about lipid checking. So that concludes our episode on ASCVD risk estimation and lipid lowering. Please return for the next episode on apolipoproteins, Lp(a), and familial hypercholesterolemia.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.